Welcome to HHQI's Evidence-Based Practices for Improving Your Wound Management Program webinar. I'm Shannon Wright, HHQI Director. We also have the following HHQI team members on the call today. We have our RN project coordinators, Cindy Sun, Misty Kevich, Crystal Welch, and Sharon Miller. We're also joined by communication specialists Misty Dyke and Andrea Lefke. We have a few housekeeping measures before we begin the presentation. The slides are posted on HHQI's website. Misty Dyke will post the link in the chat box. You may need to click on the chat box button on the bottom of the screen to bring it up. Go ahead and do that now because we're going to be using the chat box throughout today's presentation. Note that all participants' phone lines are currently muted. Please use the chat box or the Q&A box to post your questions and comments for the speaker as we go along. We will entertain as many questions as possible, so please post them early. We're really excited about today's webinar presentation. I will introduce you to our guest expert here in just a couple of minutes. Today's presentation will be 2 hours in length related to the amount of important content being provided. The webinar is being recorded and will be available by tomorrow. The session is approved for 2.25 hours of continuing education credits for nurses by Alabama State Nurses Association through the American Nurses Credentialing Center's Commission on Accreditation. Also, the session is approved for 1.0 continuing competency units by the Federation of State Boards of Physical Therapy. A link has been provided on the slides to check to see if your state accepts the PTCCUs from this organization. You will need to watch the live or recorded 2-hour webinar and complete reflective questions and evaluation in HHQI University. We'll have detailed information at the end of the presentation. Any questions related to CEs, please contact our mailbox at hhqi@qualityinsights.org. That email address will be located at the end of the presentation. After this webinar, the learner will be able to identify 6 key components to develop a standardized wound management program for home health patients. State 3 benefits of utilizing a home health interdisciplinary team approach for wound management. Describe 2 ways wound quality measures will affect the home health patient-driven groupings model for reimbursement. Discuss 2 wound management practices for palliative and hospice populations. I'd like to introduce you to our guest expert and a partner with HHQI. Myra Varnadu has been a wound ostomy certified nurse specialist for nearly 25 years. She has actively worked to deliver wound healing services in a variety of healthcare delivery settings and under a variety of job assignments, from being a staff nurse caring for wounded patients to the consultant making recommendations for evidence-based treatment plans. Myra has maintained WOCNCB certification consistently since 1995. She is also a certified foot care nurse. Myra currently serves as the Director of Clinical Services for Castrata, which is a virtual wound consultation organization to assist with evidence-based quality of care. She has also served as a technical expert panelist for HHQI for the Wound Management Best Practice Intervention Package, including writing the section on technology. At this point, it is my great pleasure to turn today's presentation over to Myra. Myra?
Myra, you might have us on mute. Can you double check your phone?
Okay. Thank you so much, and I'm so happy to be here with you today to talk about wounds. The first thing I would like for us just to talk about for just a moment, though, is to begin by identifying the scope of the wound management problem that we're having in the United States, and then discuss a variety of factors that contribute to this problem. As you can see, the U.S. Wound Registry, they've noted that there are over 6.5 million people in the United States who have a chronic wound, and that represents an annual cost of over $39 billion. And that, as you can well imagine, is going to continue to trend upward. We see that among the 33% of home health patients who have a wound, that the majority of those are surgical in nature, and those are followed by pressure injury and venous insufficiency wounds. Among the 35% of hospice wound patients, about half of those folks had pressure injuries. About 30% had a wound mix of surgical wounds, skin tears, fungating tumors, and then about 20% have vascular ulcers. And those could be venous or arterial in nature. So one of the biggest, most difficult issues we have to solve is that there are so few wound specialists to care for the many wound patients who really need and deserve the expert care available. There are 900 patients for every single board-certified wound specialist in the United States. The even bigger issue we have is that an overwhelming majority of experts, about 90%, do not work in post-acute care. So that is a big deficit in those settings for that type of expertise. We know certainly that wounds can be very expensive for you to care for when we consider just dressing changes. The products we use, the advanced wound products, can be very costly. So you ask sometimes maybe why would we even use them? They cost so much. Well, the advantage of using advanced dressing as opposed to just traditional gauze that we've used for many, many, many years is that the advanced dressing is used typically over an extended time frame, and it has a very specific purpose that interacts with the wound. So that can decrease the need for frequent dressing changes, which is certainly a benefit for wound healing. We know that the less we are messing around with a wound, the less we are manipulating it, and really doing so unnecessarily, that really can delay our wound closure. So it's important that we understand that. The other thing is labor costs can also be an issue when we're providing wound healing services. So we don't want to disrupt the wound healing process unnecessarily. So when we look at wound quality issues, we see that from the 2013 HCUP data, there are several common postoperative conditions that demonstrate a marked increase in 30-day readmission rates, and we know how important that is, readmission to the hospital. It's important that, to identify the specific conditions in your agencies that would fall within those 30-day readmissions. And if that's not data that you are currently keeping up with, that's something you really do need to know. So clearly the way your agency cares for wounds is going to also affect your star ratings and your outcome measures, such as the percentage of patients with pressure injuries that are new or perhaps they're worsened. So wound-related liability is a big, big problem. That's one of the biggest problems that we seem to face these days. Once we're able to scientifically identify that some pressure injuries were preventable, and that was several years ago, we were able to see that, then personal injury malpractice cases related to pressure injury and then other complex wounds have really increased. The litigation is really very high now, with some of the recent judgments being as high as over like $300 million. So one point I would make to you right now, and I will reiterate this a couple of other times, is it's so important that we remember that families are taking videos and photos. Patients are taking videos and photos. So if we aren't, then everybody's going to be relying on what the family and the patient are presenting as far as a video if there is a litigious issue. So very important that we're remembering that as far as what we do to document as far as photographs are concerned. So for just a moment, we're going to do this is a patient I had. His name is Jack, and I want to do a little scenario about Jack so you can understand kind of what we're talking about here. Jack was just discharged from the hospital. He has CHF, and he had an exacerbation that required him to be on bed rest. This is Kate. Kate is Jack's home health nurse. Now, she is a generalist med-surg nurse with very limited wound healing experience. And let's face it, you know, for the longest time, even before I became a wound specialist, I was a nurse who took care of wounds, and I took care of a lot of wounds, but I wasn't a specialist. I did what was told, what I was supposed to do, but I didn't necessarily understand everything I was seeing or why I was doing something. So it's important that we're trying to identify what learning our nurses, our generalist nurses, are going to require. So in this case, Kate needed more information. She was going to stage this. She said it was a stage 2 pressure injury. This is his wound. It's on a heel, and I will tell you it is a heel ulcer. Now, my question to you is this. One question, is the wound etiology correct? Is this indeed a pressure injury, pressure ulcer? And then the second question would be, is it staged correctly? What do you think?
It's time for an HHQI polling question now. Please enter your answer on the poll. It'll pop up on your screen in a second or two, and select the best response with just the photograph on the slide. What is the correct stage of Jack's heel pressure injury? Is it stage 2, stage 3, stage 4, or not applicable? It is not a pressure injury or ulcer. So everybody is entering their results now, and here in just a moment we'll take a look and see what everyone had to say when entering their polling questions related to Jack's heel pressure injury. Looking at the results, we see 70% of you said it was stage 3, 6% said stage 2, and 4% said not applicable. Myra?
Well, very good. So the answers would be yes, it absolutely is a pressure injury. Not at all uncommon that we see those on heels. And the second answer is no, it's not accurately staged. So those of you who said B, stage 3, that's 70% of you, you were absolutely correct. You were absolutely correct. We need to understand that misstaging results can result in the loss of additional non-routine supply dollars just through the end of this year. But that is important. So if Kate said stage 2 and it's a stage 3, we left some money on the table because it was actually a stage 3. And that's kind of important for us to consider, as I said, though, through the end of the year. Okay. Now, I want to talk just a few minutes about developing a standardized wound management program. The wound management program elements key elements will include your policies and your procedures, that you have evidence-based practices in place, that you use a comprehensive wound formulary, that you have access to wound specialist expertise, and that you have clinical competencies and staff education that are ongoing as needed. So let's just take a few minutes just to investigate these a little more closely. When we're looking at our policies and procedures, it's essential that they are, one, interdisciplinary. That is so important because we know it's not just the nurses, it's not just the doc, it's not just the therapist, it's all of us together that are participating in the patient's care, but the most important person and people being the patient and family members, and they're right in the center of that care. So it's important that, you know, whatever it is we're doing, that we are demonstrating an interdisciplinary approach, and also that we are reflecting the latest, best evidence in our practices. Also, you need to include a policy that's going to deal with any photos or video imaging that if you utilize them. And I'm going to tell you again, I do hope you are taking photographs. These images are extremely important. And as I said, if you don't take them, then you can be pretty sure that your patients or their loved ones are taking them. So you want to be the ones who have on record the properly taken photograph that is measured correctly and really documented well. We need to make sure that our policies include complete wound assessment and documentation and a description of the wound management plan that's being followed. We need a head-to-toe skin assessment every single visit, and it's important that we're ensuring that the Braden scale is also completed. When we say wound management, I want to talk about that just for a minute because we're referring to not only the wound dressing plan that's being used, but we're also representing a comprehensive view of the other essential components. So, for example, if a patient has a pressure ulcer or pressure injury, the dressing is, sure, it's very important, but other things that are, I would say, equally, if not more important, are things such as, do we have those individuals on a correct surface? Are we repositioning them the way they need to be repositioned? What about nutritional supplementation? All of those things would be part of the wound management plan. And again, those are going to address a much bigger view of the patient's wound care. Our wound healing knowledge has grown substantially since the days of using gauze and betadine sugar. Gauze has been around since heaven's, early Egyptian days. They're the ones that came up with gauze. So we have several. We've had wounds forever. Man has always had wounds, and there have been a variety of ways to deal with them. But interestingly, we learned back in the 60s that wounds will heal quicker and more completely by way of moisture as opposed to drying them out or leaving them just open to air. And I can't tell you how much of the time I still see that. Just leave it, the recommendation would be leave the wound open to air. We really should not do that, and particularly if your patient is in a setting where they can be exposed to, pathogens and organisms. You want to keep them clean and covered. So today, rather than gauze, so much, we use a variety of advanced wound dressings and therapies that have really the moist wound healing properties that are going to support and sustain wound closure. Advanced wound dressings are products that provide specific qualities that are needed to promote wound closure. For example, when a silver foam dressing, you might use a silver foam dressing that would be for a wound that would need 1, silver, which is antimicrobial, and then 2, would need absorption. So when I would use that kind of dressing, I would be looking at those things. How much exudate do I have? Okay. Do I need to add an antimicrobial agent? Those types of things. The goal is to change our dressings as infrequently as possible. We know that the routine disruption of wound closure will delay the disruption of our wounds will delay closure, and not only in time but in efficacy. Wounds, here's the bottom line. Wounds don't close at body temperature. They close at body temperature. They don't close at room temperature. Let me repeat that. Wounds close at body temperature. They do not close at room temperature. So every time a dressing is opened or it's removed, the wound is going to cool down, and it may take hours. It can take 8, 12, 16 hours for that wound to warm back up to body temperature and then resume wound closure. So we need to remember that some acute wounds can become complex chronic wounds when the essential wound bed elements that support moist wound healing are missing. I have seen abscess wounds that should have closed in, say, 2 or 3 weeks. Maybe they would have had a packing 2 or 3 times a week, but within a couple of weeks they would be resolved. I have seen some of those wounds that extended months, unnecessarily, honestly, because they received BID or daily dressing changes for an extended amount of time, and it really delayed the closure, did not maintain the moist wound healing that we were so seeking. So I want to talk for just a minute about gauze. Gauze is certainly, it's been around for a really long time. It's available in a wide variety of forms. such as sponges and rolls and wraps, and it has a multitude of important uses in wound healing. Certainly, we use gauze for cleansing, for light packing, but using gauze routinely as the primary dressing option really no longer meets the clinical standard. Wet to dry dressings are commonly ordered still. And really, those are used for mechanical debridement of necrotic tissue. Those are really not the option for a long-term wound management plan, a dressing plan. Those are just very episodic that we would use gauze. It's important that we recognize that when we use wet to dry dressings to mechanically debride, that's an exceedingly painful kind of a method of debridement to use with our patients, and there's so many other ways to debride that really isn't even something that we consider so much anymore. And again, the reason that that's such a problem, the wet to dry gauze, it's non-selective. So what you do is you moisten the gauze, you place it in the wound, you let it dry. And when you're removing that gauze, you are not going to moisten it to make it feel better for the patient. You are removing it just as it is, and with it you will you'll bring necrotic tissue out of that wound onto that gauze. But guess what? You're going to also bring some healing tissue as well. So that's just a reason we just kind of don't use gauze so much for wound dressings anymore. So a short term maybe would be an okay if you have negative pressure that fails and you need to do something just to to dress the wound, keep it moist. That's fine, but that would be a very short term measure. We want to develop evidence-based wound management strategies, and there's a variety of links at the end of this presentation for you to reference in your quest for up-to-date wound management information. But just some good resources for you to know about, and I'm sure you're familiar with many of these: the Cochrane database, Wound Healing Society, these other organizations, the WOCN Nurse Society, AAWC, National Pressure Ulcer Advisory Panel. Those are all good references for additional wound information. Our documentation should be complete and absolutely accurate. So the essential information that we're going to always want to include is the wound type and etiology. That's key. That is so important because you know what? Knowing the etiology of the wound is going to drive how we manage it. Has everything to do with our management plan. So we've got to know the type of wound, the etiology of the wound. We need to remember that the only staging we do is for anything that's pressure related. We need to document the location. Please use correct terminology, for example, anatomical terms such as if it's on the bottom of the foot, instead of saying the left bottom of the foot, you would say the left plantar foot. That's important. Our dimensions need to be provided: length, width, depth, undermining, funneling. We want to identify the type and the amount of exudate. What does that wound edge look like? Do you have an attachment of the wound base to the surrounding skin? And what does that surrounding skin look like? Does the patient have wound pain? Is there wound odor? And then, certain other things, for example, particularly like with lower extremities, would be identifying, is there edema in that lower extremity? Very important. Certainly, you need time and date identified on your documentation. You want to assess all your wounds at least weekly, unless there is a special situation where a wound is covered and cannot be viewed. So, for example, if somebody's got like a total contact cast on and it can't be removed until they go back to see the podiatrist, then, that would be a time you couldn't assess it, but you could certainly document it that it's covered. If you've got wounds that are showing minimal progress, then you're going to want to identify why the wound has delayed healing. It could be related to comorbidities. It could be a secondary complication of their diagnosis, or perhaps this is a hospice patient and healing isn't the goal. You're going to need to initiate prompt interventions to address the issues identified. Documentation should always include any MD contact, very important, as well as regular communication with the patient and the family. You want to document the educational information that you provide. That is so key. And you want to review that information and document that you have reviewed it and what is the patient's response to the education. You want to verify that they understand or they don't understand, or if there's something that you need them to demonstrate, as in how to do a wound dressing, that all of that is well documented, that you have instructed the patient and that they have demonstrated successfully. So important that that is done on a regular basis. And then as far as wound photography is concerned, you must have a policy or a guideline. That is so key. You must have a patient consent, and if you use wound photography should also include video imaging as well. Remember, this is a part of the medical record. So important. I mean, this is not the wound assessment completely, the photograph, but it is certainly a big part of the medical record, and it is a huge part of your overall assessment. And of course, any kind of photo transmission must, you must ensure that your policies and whatever your processes are maintain HIPAA compliance for photos to be transmitted. Very, very important. Serial photos are really, really valuable, very beneficial, and in this slide in particular, this provides an impressive visual demonstration of wound changes that have occurred. Of course, there's other documentation, but you can see very nicely, the improvement just from the view of looking at these images. Now let's talk just a minute about a wound formulary, because that's a really important, wounds require a lot of dressings and a lot of products. So having a product formulary is going to be a very effective way for you to ensure that, whatever products you're using, they've already been evaluated to provide high quality and that they're financially attainable. A set formulary is also going to help your staff to gain increased familiarity with different products. They're going to use them more appropriately, and it's going to decrease the chances of you using redundant products. I look on some folks' formularies sometimes, and they may have like 4 different foam dressings and 3 different alginate dressings, and that's just not really necessary. A lot of those are comparable, so you need to just maybe identify, maybe 1, maybe 2, but having that many options is just not going to be a good deal. You're going to get confused. Folks will get very confused, and they won't use them correctly. So when we're considering formulary redesign, our goals are going to be to improve the wound healing times. We want to minimize unnecessary dressing options. We want to make sure that we align our formulary with any kind of management algorithms that perhaps we use, and all of that should be evidence-based, as we know. We want to optimize our time between dressing changes. And, one thing I will tell you that is so important, we all do remember, is quality is always first, and then the cost of the dressing is second. And that is such a key piece for everybody to recognize, because sometimes we could spend a lot more money on a dressing, but if it's going to help the wound facilitate closure sooner or faster or provide less pain to the patient, those are all reasons for us to consider using a more expensive option sometimes.
It's time now for another polling question. We want to hear from you. Think about your organization's current formulary. Could you benefit from a redesign? Enter your answer on the right hand of the screen. Is it A, yes, we have too many products that often expire? B, yes, it's been a while since we evaluated ours? C, I'm not sure, but we'll discuss this with our team and leaders. Or is it D, no, we have a process in place to evaluate regularly? We'll pause for a moment as we compile the results from our audience today and then let you know what you had to say about your organization's formulary. 37% of you said no, we have a process in place to evaluate regularly. Second place with 16% was yes, we have way too many products that often expire. And then tied for third place is options B and C, which are yes, it's been a while since we evaluated ours, and I am not sure, but we'll discuss this with our team and leaders. Myra?
Very good. The general process that we're going to use for formulary redesign, and I think this is a nice little guidance for you to have if this is something that you're wanting to do in your agency, is the first thing you need to do is just review your existing formulary. Where does it meet your needs? Where does it not meet your needs? You need to audit the current use of wound dressings. You know, you may have things on your formulary that are never used. Well, that may be something that you need to consider changing. You want to certainly inventory the existing wound dressings. You want to develop new formulary and management guidelines for use. That is so important. And if you've got protocols, so important that your dressings and your formularies all tied into your protocols as well. Any new staff, it's so important that you introduce new wound dressings. Not just new staff. When you have staff and you have new procedures or new wound dressings that are going to be used in your entire agency, that should happen as well for those folks. So, you know, your brand new folks as well as your established folks, they all need information on the new wound dressings, and not just what they are, but how to use them. It's important that we're establishing an approval system for using some non-formulary dressings, because there are some that we're constantly having new options that are being developed, and there may be some that are not even, when you did your formulary, they weren't even available. You know, you need some kind of a system so that in between times of changing your formulary up, that you still have access to a lot of the really good products that are available. And then it's so important to certainly educate your referral sources, and that your physicians certainly or providers understand your products that you use. Here you have, oh good heaven, these are images of a variety of wound dressing types. Some of these may not be familiar to you, but I will tell you they represent the most commonly used wound dressing types that we use. So as you can see, there's a lot of different sizes and different shapes and different formulations, okay? Some are in a pad, some of them are in a rope, you know, it's just a variety. Some of them have borders, some of them don't have borders, you know, just anything and everything, it seems. So when we're going to evaluate wound dressings, we have this nice little, this mnemonic called measures that we use to identify the priorities of product selection. So just very briefly, the priorities for advanced wound dressing. Certainly you want to minimize trauma to the wound bed. When I take help, I don't want to hurt the wound. I don't want to make it worse. That's extremely important. We want to eliminate any dead space. So if you've got tunnels, tracks, undermining, that's got to be filled in. We want to assess and we want to manage the exudate. We want to support the body's tissue defense system. Absolutely do not want to be using the toxic wound cleansers. We might use something that would be a very, very, ever so short-term option. And I guess I'm thinking Dakin's solution. You know, there's a lot of mixed reviews on Dakin's. I'll tell you, there is a dilution of Dakin's that is safe for healing tissue, but it'll kill the bugs. But it's so weak. A lot of folks are like, can you really make that? So I'm just telling you, you got to be careful. If you use Dakin's, you use it in a very, very, very weak. And we do like 5 cc's of bleach and 1,000 of water or saline. That's how weak that is. So, you know, do your study. Do your research, find out what it is you need to have available to you, because you don't need a lot of different wound cleansers, really. You want to make sure you're going to remove infection, any kind of debris or necrotic tissue. You want to make sure that, you know, the wound environment is maintained. And by that, I'm talking about that it, you know, the moisture, it remains a moist wound base, that you're able to maintain, you know, that it's thermal. And by that, I mean you don't have it left open to air, and, you know, all of the warmth to that wound base is escaping into the air. And then you want to certainly protect the surrounding tissue, that peri-wound tissue, from any kind of injury bacterial invasion. With wound product standardization, we're going to accomplish eliminating redundant products, reducing the risk for incorrect use, and unnecessary dressing changes. Those are also important. We can better manage our costs for specific product use, and we can identify some options for best use with patients. So correct product use among our staff, we can facilitate that with a direct with like protocols that we would develop for our dressing selection. Also, we have guidelines, we have templates. And those are certainly a part of the education, but they're not all of the education. It is so important that when you are bringing in new products that you have someone who is knowledgeable about that product who can come in and provide the education that your staff needs. So, for example, if that is something that has to be wrapped or say it's a new type of negative pressure, everyone needs to be educated on that and everyone needs to have competency demonstrated. And we're going to talk about that a little bit more. But I got to tell you how important that is when we're doing this. So your product reps can be very helpful to you. A lot of times companies will have clinical folks, and that's even better. But so you've got a wound care specialist who's coming into your agency and showing you how to use these different products. So that's really, really helpful. So when we're considering formularies, we need to ensure that we're addressing all of these specific dressing types. We have certainly cleansers, we have primary dressings, we have secondary dressings, which are the topper dressings. We want them to absorb or we want them to hydrate, we want to fill if we need to. We want some dressings, we want them to be what we call quote-unquote active dressing. So an example of that might be a collagen dressing, that it has a very specific use actively to deposit collagen in your wound base. So you need to have access certainly to all of these different types. Very important. Our wound products, just generally when we're just trying to decide which options are we going to choose, we've got to take into consideration the specific wound etiology, the type, the tissue type. So is it necrotic tissue or is it granulating tissue? Presence or absence of infection. Does the patient have pain? The varying amounts of exudate. If a wound is really wet, we want to dry it up a little bit. And if it's really dry, we want to moisten a little bit. We want it moist. We don't want it wet. We don't want it dry. So those kind of things are going to be really important when we're using different dressings. And honestly, a lot of the time, once a wound has gotten to the point that it's a clean wound and we're just growing in tissue, really the amount of exudate has everything to do with the determination of what type of dressing we're going to use. How much absorption do we need, for example? We need, of course, to know the location, and certainly depth is essential. We've got some wounds that when we're measuring, if we're just going to do the surface area, length and width, we may not see a lot of change for a while, but boy, if it's deep, we need to know that depth measurement because that's what's going to be growing in before we start seeing the changes on the surface. So that's really important. And then, absolutely to have well-defined goals for wound management. What is our expectation? We recommend reviewing dressings for formularies according to learning about the dressings by generic category first. That's really helpful. Compare new products with those that already make up the category. Also, it's important to select the safest and the most effective options. User-friendliness is so key, and then cost-effectiveness is most certainly possible. You want to change dressings based on the patient, on the wound, and on the dressing assessment, not on standardized routines. So back to my point just a moment ago about that the amount of exudate can influence the type of dressing you're going to use. That's exactly what I'm talking about in this point. You want to change the dressing type based and the dressing based on the patient wound and that assessment that you have. That's very important. Not just because you think it's, it says 3 times a week. Okay, we need to change it 3 times a week. In actuality, maybe that wound now is only going to need 2 times a week, but that's got to be communicated to the folks that are helping to make the recommendations. Also, as our wound moves through the phases of wound healing, it's important that our dressing protocol is going to evolve. so that it will optimize wound healing. So that is key. We need to look at wounds from start to finish. So if they need to be debrided, we need to follow all of those measures for during debridement. What do we do after the wound's debrided? And we're going to just grow in tissue, those things that we're going to do. What are we going to do then next? So our protocols have got to establish very clear delineation of all of those different phases of wound healing and what it is you're going to be using to optimize your wound healing. You want to practice and play around with dressing materials, because that way you're going to learn more about what they do. And that's really where the sales reps can be so helpful, because they bring in, they can bring in a lot of samples that you can mess around with and play with and see exactly how much does it absorb, or a variety of different attributes of the dressing. So I encourage you to try to do that. Try to kind of have some experience with these dressings before the first time you're going to actually apply them. And then clearly wound management, for when you look at this, at this image, certainly what we're going to do for those first two wounds being necrotic and the second one being extremely desiccated, okay, what we're going to do for those is going to be very different than what we're going to do for that third wound, which is a beautifully granulating wound that we just need to support, okay? So my point in telling you that is we're going to decide on whatever our options are going to be for wound dressings and our management, certainly based upon what type of tissue there that we're seeing in the wound. Here are some amazing resources for you. If you're not familiar with these, please take a few minutes and just go to these sites and check out what they have to offer. They've got great information on products. They've also got great educational information that really would be of benefit for anybody that cares for patients who have wounds. So I would encourage you to take a look at these websites, because they're really, really, really good. Okay, now let's talk about having the availability of a wound specialist. And I can tell you that that's critical to the success of your wound program. It really can make all the difference in the world, because I will tell you that as a wound specialist, I can anticipate what's happening with that wound, because I've really spent so much time doing wounds, and I've seen a lot of wounds, and I had that experience, and I had that education. And that's great. I didn't always have that, okay? So having someone who is able to provide you with that information is really invaluable, because it gives you kind of an idea of what you should be expecting from the next point of, here's the next stage of what I expect we're going to see with this wound, and this is what these are going to be our goals for that. So you can have those kinds of certainly communications, which are so important, and everybody kind of has a better idea of, where are we going with this wound.
It's time for another polling question. We want to hear from you. Does your organization have or use a wound care expert? Your options are A, yes, one or more nurses. B, yes, one or more nurses or therapists. C, yes, we use a consulting company. D, not at this time, but we're considering it. Or E, not at this time. Please make sure you've got your answers in the polling box in WebEx on the right. And here in just a moment, we will share the results of what everyone participating in today's webinar had to say about whether your organization has or is using a wound care expert. It appears the number one response at 44% was yes, one or more nurses. Second was not at this time with 20%. Third was yes, one or more nurses or therapists. Fourth was yes, we use a consulting company at 8%. And in fifth place was not at this time, but we are considering it with 7% of our respondents. Back to you, Myra.
Very good. That's good to know. Okay, so access to wound specialist expertise is very limited, and, I've already told you that. That's one of the bigger problems. We say how great it is, but then if you can't get that help, that's certainly not very good. we've got studies that clearly show that home care agencies that have access to a wound expert will demonstrate overwhelmingly improved closure outcomes than those who do not have that same access. So we have a variety of access options, such as you can hire someone who is already a full-time or a part-time wound specialist. You could contract with somebody outside of your agency, or you could use, your staff you currently have. You could identify folks who would like to get that education and certified in wound healing. Or you can outsource the wound expertise, and it sounds like you all do a variety of each of those. Just very briefly, I want to tell you about the different groups that are available if you do want to get that education and the certification. One is the Wound Ostomy Continence Nurses Certification Board, and they do wounds, ostomy, and continence, and they you have to precept with those folks. It's a fairly lengthy process. It's a formal education program. It's only for RNs with a baccalaureate, and it was really one of the very first wound education programs available. So those folks would be like CW OCNs. That would be that certification someone would get. And then we have another, which is the American Board of Wound Management. ABWM is that certification board, and they certify all healthcare professions with a minimum of baccalaureate degree. And again, you have to be licensed healthcare, but you can be a nurse, or you can be a therapist, you could be a variety of different folks. There are dietitians. There are a variety of folks that will get this certification. And the requirement is you have to have 3 years of direct wound care experience with patients, and there's a board exam that has to be taken every 10 years. Then there's another group, the National Alliance of Wound Care and Ostomy. They certify all healthcare professionals, and regardless of level of academic education. There's active license is a requirement. You have to have had an active license for the past 4 years, and you have to be licensed. A licensed healthcare professional currently. They have a completed skin and wound management course requirement, and then you have to have 60 contact hours specific to skin and wound care. It's just the scarce availability of wound experts. That's the thing that is really very difficult sometimes. Less than 0.2% of nurses are wound certified, and then we know that almost none of those folks are in home care. The vast majority, as I just told you, 90% of those folks, they're not in post-acute. It's an expensive resource, so you want to make sure that whatever you decide to do as far as bringing in specialty nurse wound specialist care, that you're taking a look at that expense. You may have better utilization. $90,000 is the average salary that would be paid. So take a look at where could you get better utilization of that money. Is it with another company, or is it with a part-time person? All of those options that we just talked about as far as identifying how to get that expertise. The other thing that is essential that we have to ensure is that patients meet the criteria for medical necessity for home health wound care. That is such a big deal. That's always been such an important component of healthcare. So specifically for wounds, they would have to have an open draining wound, or a wound that would require negative pressure irrigation or perhaps packing. It could be wounds that have exposed arteries or veins. It could be a post-op wound that has a high risk for dehiscence, or a post-op wound that is already dehisced and has other complications such infection, for example. Mm-hmm. And then we need to really just identify those complex wounds that are going to require skilled care. That's key. Evidence of employee education and demonstration of the nurse competency to perform a specific wound-related intervention is absolutely imperative for legal defensibility of your program. And, you know, I'm saying nurses in a lot of agencies, there are therapists who do wound care. So forgive me for any of the physical therapists, OTs, who provide wound care. I don't mean to leave you out because you have a very, well, an amazing opportunity to really give us a lot more of your expertise with these wound patients. So forgive me for saying nurses all the time. But it's really important that the education and the competency is done. That is so key because, you know, there's, again, we're talking about defensibility, and I've done plenty of home health defense work for litigation, and I will tell you the thing that I see being one of the biggest issues is that the wound documentation is not adequate. So that's going to be key, particularly the education. For your clinical competencies should certainly be done for any new hires, and then again, your clinical staff annually. You want to make sure that these elements are considered, such as your proper use and scoring of the Braden, and not just the Braden, but also those subscales. Identification of wound type and etiology, staging of pressure injuries, demonstration of proper wound measurement, how to properly measure a wound, and then how to properly assess a wound. Our wound education is so critical for us to deliver excellent wound care. So, you know, we want to provide an opportunity for additional wound education and accreditation. Our clinical staff have got to be educated on the established evidence-based best practices that we're using. They need to understand application of wound dressings and compression therapy. I can't tell you how important it is that your staff are educated and that they have demonstrated successfully that they can apply a compression wrap, and not only a compression wrap, but also that they can use a Doppler to obtain a screening ABI measurement, ankle brachial index measurement. And the reason we would want that is we need to know that our patient with a lower extremity wound does not have PAD before we start applying something tight to their leg, because we could really, someone with PAD, we could really set them up pretty badly if we applied the compression to them. So that's very important. And then certainly, as applies to the therapist, using E-stim, and you have some therapists that can go into the patient's home and do debridement. That's excellent, very much what we need. Now, the last program element we're going to discuss are wound metrics and certainly outcomes reporting. And that's kind of really big. I have to tell you that I'm so amazed sometimes when I ask somebody their healing rates that they look at me like I have 6 heads, because they have no idea what we're talking about because they don't maintain their data. I'm just going to tell you, you know, it's essential for you to be able to know where you're going and how to make changes in your program. You have to know where are you now? Where do you stand? What are you doing great? What do you need to improve? And, you know, where do you want to be? Where do you want to go? So what I would tell you is, you know, some of these are nice to have metrics and aren't required. The ones on your slide here that you have by CMS and OASIS D, and that, for example, would be under your ED visit rates, surgical wounds, and chronic wounds. But the rest of these, you really do need to know these. I mean, and it's nice to know surgical wounds and chronic wounds and your rates. That's all great, but you're not required anymore by CMS or OASIS D to have that information. So we want to know your acute hospitalization rates, and we need to know what's the percentage of your patients who have 2 or 4, stage 2 or 4 pressure ulcers that are new or have worsened, or, you know, what's your percentage of healing? Like I told you, a lot of folks can't tell you that. And then most certainly we have to know, are our patients satisfied with the care that they're receiving?
It's time to hear from you again, but this time we're going to do things a little differently. We're going to be using the chat box for your comments or ideas. If you don't have the chat box open, hover over your WebEx player, look at the bottom. It's a little blue button with a bubble on it. You can click on that to bring up the window. So please, at this time in the chat box, let us know, how is your agency collecting hospitalization and emergency department data related to ostomies and wounds? If you could enter some answers now in the chat box, we'll share a few of those sample examples with you before we resume the conversation. It looks like great answers coming in from our participants. A lot of people are saying SHP. Some are saying not collecting at this time. Another response saying through our QAPI program, spreadsheets, a quality coordinator. Another person said our electronic medical record collects that data. Surveys, usually when we have a home assessment, utilizing CASPER data and utilizing SHP data and chart audits. Another person says we are associated with a hospital, and we receive it via our electronic medical record. So that's a sampling of some of the great responses we're getting from our participants. Thank you for your input. Now back to you, Myra.
Very good. Okay. It's important that we are establishing and monitoring these metrics. For example, skilled nursing visits for one patient's worth, number of wound-related in-home visits per episode. So this is even drilling down a little bit further. And what are the number of wound-related in-home visits that were non-episodic patients? Again, you need to know about your wound supplies, your costs, per episode. That's very helpful to have that. Because if you have very similar wounds and you're following the same protocol and you've got one patient that's using 3 times more dressings, then, you need to look at, okay, why is that happening? Maybe the individual who's caring for the patient doesn't understand. So, that's such valuable data for you to collect. You need to know just overall what are your supply costs, certainly, and then what is the overall cost of care per wound patient? That's really valuable to have because, again, you can show a lot of improvement if you're able to pull together this different information. It's very important. So as far as our reducing wound-related legal risks, just using those best practices to reduce our liability, particularly for pressure ulcers. We want to assess the risk for pressure ulcer development in our patients to begin with. Very important. We want to be very knowledgeable, particularly for our patients in assisted living facilities. We've got to remember that the home care nurse, it's very important that the home care nurse is communicating with the agency to let them know if the patient in an assisted living facility has a stage 2 that has not shown improvement for 30 days, or that they have a patient who has a stage 3 or stage 4 pressure ulcer, because those patients are going to need to receive care in an alternate site outside of the assisted living facility. They are not allowed with stage 3 or 4. So that's really important. They may have to be moved, to a skilled nursing facility at that point. Real important, though, that the home care is doing that. They're the ones that are responsible to make that notification. Reducing wound-related legal risks can be promoted by using standard interventions for those at risk. For example, when a patient presents with a certain kind of a skin issue, that you're using a particular type of support surface, for example. If they have a heel pressure injury, if they've already got the pressure injury, pressure ulcer on the heel, floating those heels with pillows that doesn't work anymore. Okay, that's already been proven not to work. At that point, they need some type of a heel offloading device, that kind of thing. If your patient's in a support surface in the bed, they need the same thing if they sit on a chair or in a wheelchair. You want to make sure that other things that you've got, standard interventions, repositioning patients, and that you're educating folks on how to do that pressure redistribution. You want to make sure you have a nutritional consult to address any kind of deficits. The patient has fecal and urinary incontinence. That has to be addressed, particularly in home care as far as how the skin is maintained. And then you want to leverage an interdisciplinary team. That is so important. Your physical therapist, you want to consult them for any kind of mobility issues. They can provide advanced wound care modalities such as E-stim and ultrasound, and they can provide sharp debriefing too. Your OTs, they can improve the ability to perform wound care, which is really such a benefit that those folks have to functionally be able to assist patients. Your speech therapists, they can absolutely assess and treat for swallowing issues that really can affect the patient's wound because of, if there's issues with swallowing, there may be issues with nutrition and hydration as well. And of course, your social workers, your medical social workers, they're really, really, really helpful. They're some of the most helpful folks I've ever worked with to assist as far as the financial and psychosocial support, certainly that our patients need. Our dashboard, our wound metrics dashboard should have certainly quality metrics that would be related to our hospitalization rates, our ED visit rates, our newer worsening stage 2 to 4 pressure injuries or ulcers, the percentage of wound healing that we see with our patient population, and then certainly the patient satisfaction. Financial metrics that we're going to want to see in that dashboard are going to be, again, skilled nursing visits for wound patients. What are the number of wound-related visits per episode and the supply cost, and then again, the overall cost of care per wound patient. It's important that we understand that as far as best practices related to liability for pressure injury, pressure ulcers, we now know that some wounds are unavoidable. Okay, so it's important that that we do understand that. Now, it's also important to know that the vast majority of them can be prevented, and so they are avoidable. And it is extremely important that our documentation has everything in it that we need. If we think that a patient acquired an unavoidable pressure injury, that we know we are doing everything that we are supposed to do. We are following everything that is recommended by best practices. When you go to the National Pressure Ulcer Advisory Panel, you're following all the recommendations that they provide. Okay? And you got to have that well documented, because if a patient does acquire a pressure ulcer, I will tell you, in the home, they're going to say it was always avoidable. And it's going to be really important that your documentation is going to reflect otherwise. So I would just tell you, documentation, and I keep saying that, but your documentation is so important. It is so important, and not just that you're documenting what you see or what you're doing, but if the family has a responsibility in that you're documenting that they have been instructed and they have demonstrated competence to do whatever it is you are having them do, and that you reiterate on a regular basis to them what they need to be doing. We want to, with the wounds that are showing minimal progress, we want to have something, we want to intervene on those very quickly. We don't want to just let them languish and wait 2 weeks and then all of a sudden we've got a patient who's septic. We want to identify those early signs and symptoms of infection and start early to take a look at, this may be one of the reasons we're not getting so much progress with the wound. We want to follow the standards of care, certainly in our selection of proper dressings, adhering to recommended frequency changes, the dressing changes, and then, taking in consideration the patient's situation and their preferences too. That's real important. All has to be documented well. The other thing I have to tell you, and this is something that we have heard from the time we were all in healthcare, is it's just so important that somebody is inspecting the patient's entire body for skin breakdown head to toe. That is just so important. And not just documenting well that you are doing that you're doing that routine assessment and anything that you find different from the last time. So, you might want to consider becoming a wound center of excellence. We know now that many agencies, as things currently exist, they don't actively market for wound care patients, and they kind of, make referral decisions based on the presence of a wound, whether they're going to take the patient or not. And it could be because wounds can be very expensive, extremely expensive. But you have a great opportunity here in building and doing the things that we've just been talking about to build up your program, to become a wound center of excellence. You want to leverage for increased referrals once you get all those different components together. You can go out then because you're organized, you know what you're dealing with, you know what your data says, and you can leverage for increased numbers of wound referrals. You can partner in value-based care delivery models, which you're going to see that more and more and more. For example, with some of the bundle payment options, some of the projects that are taking place, as well as working with accountable care organizations. Because those are value-based programs. Everybody is in it for the right reason, and the reason being to get the patient well as quickly as possible. And then, to be able to really pull this together, you've got to have robust data that is, about your wound management program, access to the experts, as I told you, and then develop high-functioning wound teams. I can't tell you how important it is when we go into an agency. I love to be able to work with a set number of people or set group of people who are kind of the super users, the folks on the ground that are going to be the ones that receive a lot of the information, and they're going to help to disseminate it among their agency. So, there are great ways to develop these teams, and that can be really extremely, extremely successful for your agency and for helping your patients.
At this time, we're going to do a little Q&A. We've got quite a few questions that have already lined up in our Q&A box, so we will address some of those now, starting with one question that references an earlier photo that we saw in the presentation. This individual says, that photo appears to have slough. In a recent training I attended, if there was any slough, the wound was unstageable. Is that correct or not?
No, not any amount of slough. If you can see the wound base, that's okay. But if you've got less than 25% of slough, you should be able to stage that. Less than 25%.
Next question asks, how often should the Braden scale be assessed and documented in the home care setting? Is there any evidence-based information regarding this?
There's evidence-based information about performing the Braden, but what's interesting is depending upon the site of care, the frequency is really determined pretty differently and inconsistently. So, for example, let's use acute care. That's easy. If they're in the ICU, that's done every shift. If they're a patient on the floor, it might be once a week. If they're in the outpatient setting, it might be once a month. In home care, I've seen a variety of different frequencies for that, and I'm going to give you a preference. There isn't anything that I am aware of, and I will certainly research this and find out. There's nothing that I know of that says that there is a certain frequency for home care. So I would tell you, I would like to see it every week, personally, I would. And I'm a wound care person, and maybe that's why. I don't think I've ever seen an agency, however, that did weekly Braden scales. What's most important about the Braden, though, is that once you identify that, maybe there's a deficit, it's great to do that, but now what are you going to do with it? You've got to have a plan for how you're going to manage it. So say you've got a patient and they've got a problematic Braden scale. That's going to make sense to me that I'm going to really stay on top of that and make sure that whatever issue I'm seeing they're having, that regardless of if my policy says once a month or once a week, I'm going to continue every time I see that patient that I'm going to be looking to see what is the effect of that risk on the patient actually acquiring a pressure injury.
Next question asks, how can you politely educate physicians about wet to dry dressings when they are ordered? We still frequently get this ordered. Is there any documentation that we can provide politely?
Yes, there is information, and yes, you can be polite. I'm saying that a little tongue-in-cheek because, I think we all have that issue sometimes. What I would tell you is the way that I've ever been able to get that point across to patients, not just for wet to dry, but for anything that is wound-related, is I show them the evidence. The clinical evidence, and that's the beauty in wound healing. We really have some very robust clinical evidence that supports what we do. And I would tell you that for wet to dry, we've got amazing evidence that supports why you don't do it. And I'm going to give you the name of an article, and somehow or the other, we will make sure that you have access to pull this up. First thing I'm going to tell you is it's not recent. It's an article that's been around for a while, but it is still so pertinent. The information, the original information remains, what we consider today. And it's called Hanging Wet to Dry, Out to Dry. Hanging Wet to Dry, Out to Dry. And it is really well done, and it kind of goes through every reason why you wouldn't want to use gauze, from the patient to the pain to the expense to the nurse utilization of her time, all of those kinds of things. So I'll make sure somehow that is posted somewhere so you all can pull that up, because it's a good piece, particularly for wet to dry.
All right, coming up, we're going to have a brief break for everyone, and we see there are still some more questions coming in. Not to worry, we'll have more opportunities for Q&A, and we'll get to as many questions as we can during today's presentation, or if we don't get to your question, we will be able to follow up with you individually at a later time. Our final question before the break asks, if a patient is going to a wound center, may we ask them what the ABI is, or if the ABI is done, and may we make the ABI a requirement prior to admission of a patient with a wound?
Wow. Yes, you can certainly take the ABI value from someone else. You don't have to have done it. You just need to know what it is. That's important. That's the first thing I would tell you. So as far as like specifying that you will not take the patient unless they have an ABI, what I would tell you is this. We're talking about screening. We're not talking about something that's huge diagnostic workup. And the thing I would tell you about the ABI is this. You want to know it. You don't want to lay hands on a patient in a way that you're going to say, for example, do something that will debride a lower extremity wound that afterward you find out, okay, we've debrided this wound and now we have no blood flow to close it. Okay, you don't want to be in that position. You want to know ahead of time that the patient already has got a flow issue before you start doing anything. So that would be whether it's debriding or compressing or whatever. Plus, if the patient's got PAD, they need to be worked up. We don't hang on to PAD wounds, and the reason we don't is typically, the number one referral for those folks is get them to a vascular service, because really a lot of these folks need to be revascularized, and that will fix their problem. Some of them are not candidates for revascularization, and if that is the case, then we manage them just as conservatively as we possibly can, but we do that knowing, okay, what we have. We're managing them knowing they've got PAD that really can't be treated. So much better to know that than to not know that.
Thank you, Myra. If we could advance to the next slide, that will initiate a brief break for about 5 minutes or so for everyone, and we'll give you a heads up about a minute or so before we resume. Make sure and stay tuned, because Myra has a lot more excellent information to share with you on today's webinar. Talk to you shortly. Welcome back to today's webinar presentation. Now back to you, Myra.
Very good. Okay, for the last part of our program, I'd like to talk just for a couple of minutes about some regulatory changes and some challenges that we're going to see. Right. This is a little bit old, but it's still current. I want to go over the Impact Act and how it applies to wounds. This applies certainly for all post-acute providers, and what's important that you know is until the end of this year, Any home health agencies who do not report will get a penalty for not reporting on the 5 quality measure domains that do include skin integrity. So what that particularly means as far as skin is concerned is the percentage of your patients who have stage 2 or 4 pressure ulcers that are new or that have worsened. So that is through the end of this year. It's important to ensure that, again, this is a lot of information we've been talking about pretty much throughout the day. Accuracy of your pressure ulcer staging, that you have accurate wound measurements, your formal program is in place, you use multidisciplinary approach for your wound patients that are at high risk, including, we're talking about your dietitian and your PT, your OT as well. So starting January of 2020, we have some new reimbursement methodology that is called PDGM, which stands for Patient-Driven Groupings Model. And the major changes you're going to see with that, it's going to move us more to value-based care, and I just have to think that's a good thing. The payment period is going to be changed from 60 days to 30 days. That's one big change. It's also going to eliminate therapy thresholds as a component of the payment. Now, that doesn't mean you don't use therapists. It just means it's going to be figured in a different way. Our therapists are exceedingly important to what we do. It also bases reimbursement on 12 clinical groupings that typically are going to reflect the primary reason for you providing services for patients to begin with. And I will tell you that the wound clinical grouping is wounds, post-op wound, aftercare, and skin non-surgical wound care is the description. And then the main reason for the care is assessment, treatment, and evaluation of a surgical wound, or assessment, treatment, and evaluation of non-surgical wounds, ulcers, burns, and other lesions. The opportunity, we have opportunities to improve care for your patients. And you can care for more complex wound patients, like I said. We already know that. Based upon currently what we have as far as statistics, if you ended up extrapolating that and under PDGM, what we would see is that about 10% of the patients will be wound patients in this highest grouping, in this groupings model. And again, wound care has the highest of the 12 groupings. That's very good. And they're 25% higher than current prospective pay system. Very good. And the higher reimbursement is going to occur if the patient comes to the home health agency directly from an institutional setting, as opposed to being sent from the community, as in the doctor's office, for example. And then it's important to know that the non-routine supply costs, they're now incorporated in the base cost, and that's not something you're going to be adding in separately. You still get paid for them, but it's a little bit different way. Oh my gosh, coding and coders, they are absolutely the key for you to maximize your reimbursement. So when you establish a wound center of excellence, you've already identified the key to driving wound-related high-quality outcomes, increasing the number of facility-referred wound patients, and then optimizing your wound patient margins. And I can tell you, your coders can help you get there. Having a good coding is so incredibly important for your success.
It's time for more Q&A. We'll get back to the questions that we have. If you have additional questions, please submit them in the Q&A box in your WebEx player. Our next question asks, do all ALF, regardless of their specific licensure type, have the same regulations regarding wounds? Not appropriate for stage 3 to 4 pressure ulcer, and not appropriate to keep a patient with a stage 2 longer than 30 days.
To my knowledge, that is consistent across the board. Now, I can certainly research that, and we can address that if it's different, but to my knowledge, that would be correct. They're consistent.
Next question asks, what is the proper method to measure length and width of a wound?
Okay. It's really funny because when you go and you try to find this somewhere, in all of the references where we think it should be, it really isn't. So I'm going to tell you what we use, which is head-to-toe measurement is your length. So that would be, if you imagine a clock, that would be from 12 and 6. Those points on the clock, those are your length. Side to side would be your width. Going straight into the wound with a sterile cotton tip applicator and a gloved hand, that would be your depth. We don't take measurements at diagonals and that kind of thing. You have to have an intersection of the longest length at a 90-degree angle. Okay, so your width and your length, where they intersect, that'll be your longest length and your widest width.
Next question asks, since there's no frequency in home care for the Braden scale, would a best practice be on SOC, ROC, recert, and change in condition?
Well, certainly your start of care, resumption of care. I would say all of those times minimally, personally. And I'm giving you personal, because it's not really well designated. I'm giving you my personal opinion. Okay, are we ready to go on?
Just a couple more questions, and then we'll resume. Next one asks, can you suggest anything less costly that is comparable to Prisma? Seems to be a very popular one with wound clinics.
Yeah, there are a variety of those. I really can't speak to products, unfortunately, on this program, but I'll tell you what Prisma is. It is a collagen dressing that has silver in it. So there are others. There are other options for that. I will tell you this. Sometimes it has to do with the contract that you have in your agency and, who you get your supplies through. So there's more to it than just, I wish there weren't, but there's more to it to consider when you're trying to find better cost.
And our final question before we resume, can patients with more advanced wounds stay in an ALF if they are on hospice?
I don't know the answer to that. I do not know the answer to that. I'm sorry. That is something we will have to research that for you, because my first instinct is no, but that's something that we would have to investigate further.
All right, that takes care of all the questions in Q&A at this time. If time permits, we will break for one more time before the end of today's presentation. Now back to you, Myra.
Sure. Okay, now we're going to take just a moment to talk about palliative and hospice wound management. It's important that we understand that when we're dealing with hospice and wound patients, that there's really no definitive protocols that we follow. Typically, it's just guidelines. We really shift our focus from what's best for the wound to what's best for the patient and for the family, and that's really essential. The thing about it is we want to see wounds heal or close, but that's not always the goal in palliative and hospice wound management. So it's really important that we are approaching every patient with the possibility of healing, but understand that it maybe won't. So that's, I think that's the reality of dealing with this population, is that we have to understand that. There is something, if you're not familiar with it, it's called skin changes at life's end. I would encourage you that everybody in your facility who deals with, or your agency who deal with hospice folks, need to be aware of this. It was an initiative that commenced with an international group of wound and skin experts, and what they did was they studied several things about patients at life's end, and we know that there's specific skin changes that we commonly are going to see. We needed to better understand what's the exact nature and the science behind these complex skin changes. Nobody had ever really studied it so much. And it made us start thinking about some other things, like, is there such a thing as skin failure? We have heart failure, and we have kidney failure and liver failure, all kinds of failure among, major organ systems, but we really don't think that the skin is failing. And that kind of got us to the point of thinking, hey, this may be skin failure. It made us, this initiative also, the benefit was it really helped us look at, what can be avoidable and what can't. So what this did was this program scale, Skin Changes at Life's End, this collaborative ended up it really ended up putting us in a different thought process as far as how to deal with hospice and palliative patients. And we identified very clearly that there are a lot of areas that require additional research. The wounds we typically will see among that population, we see a lot of skin tears. We see pressure injuries, and we see certainly malignant wounds, such as fungating tumors. We do have a good number of venous wounds, and we see arterial wounds. It's important to know that if your patient had venous insufficiency prior to going into hospice, they still have it. And it may end up manifesting a little bit differently once the hospice diagnosis is in. So just to understand, hospice, that patient, it wasn't started probably when they got in hospice. That was just a pre-existing condition, but it still does impact their care. Just real quick, I want to talk about a patient we had. He was a 79-year-old male patient, and he had rapidly progressing metastatic end-stage prostate cancer. And, he was at the point in his care where he said, I'm just tired. I don't want to do this anymore. He had a sacral stage 4 pressure injury, and he was refusing dressing changes. He was refusing to be, turned in bed. And, his goal for his care were to be comfortable and to spend his remaining time with his loved ones. Now, his family, they were not at all receptive to his goals. And they really were pushing him to keep trying and to push and to continue wound care and to treat the pressure injury. And it caused a little bit of angst with them. So you have to wonder, whose call is this? So what I'm going to tell you is, as long as the patient's in a state, is in a physical and mental state to determine their care, course, they determine their goals. But the most important thing about this is something to talk about before the patient gets to this point. It's really important. That's why we need to really have conversations to say, when I get to this point, I don't want this, or I do want this, or whatever. So that when you get to that point, you're not having to try to figure out if you're doing the right thing, because that can really be difficult. And as I just mentioned, it's always a goal that we want to close wounds, but sometimes it's just not feasible. It's just not appropriate. So we have some wounds that are really more appropriate for us to use what we call maintenance care, which means that we're going to try to keep them from getting infected. We're going to try to keep them from getting larger. We're going to try to keep them from becoming more complex. Okay, or we might have a wound that is non-healing. It's a non-healable wound. We're talking about, in that case, just comfort care, including, really management of pain and odor. And that's something hospice nurses, management pain is something they do better than anybody I know. And then, just basic recommendations would be, I try to identify your patients at risk on the front end. Try to correct any underlying cause of damage if it's possible. So if it's pressure, if it's shearing, if it's moisture, try to do what you can to manage those things. You want to make sure that if you can affect the perfusion that you do, particularly of the lower extremity, you want to assess any indications to help determine whether, how is that wound? Is it going to close? Is it going to be maintenance? Is it going to be, comfort? And then the strategies for certainly the symptom management. Okay, now let's talk just a moment about technology.
And it's time for another polling question. We want to hear from you. Go to the polling box in the right-hand corner of your WebEx player and let us know, which technology does your agency utilize with wounds. You can mark all that apply. A, wound imaging software, measures and photographs. B, video conferencing, visualizes wounds. C, telewound consults, which are wound experts providing remote consults in lieu of face-to-face visits. D, other, you can specify that in the chat box. Or E, none at this time. We'll take a look at those results coming up here in just a second. And again, you can use the chat if you would like to specify something else in this area. We'll see what everybody had to say and what your feedback is momentarily here on today's webinar presentation. It looks like the majority, 59%, said none at this time. Second, we had 16% of people indicating telewound consults. Next up at 8% was wound imaging software. And then we had video conferencing at 2%. And no one indicated other and specified that in the chat box. Now back to you, Myra.
Very good. The last thing we're going to talk about is just technology a little bit, and I get really excited about this because there's so much that's happening that's going to be available to you in home care, hopefully in the not-too-distant future. We have a tremendous availability of high-quality technology options that are available now to meet the many needs that we've discussed today, particularly in establishing your wound program. Like here is an imaging software, and I use this one, and it auto-calculates the surface area of the wound, so that's length and width. It has the capability to identify color throughout the wound, which is really important to know. We're able to, the serial images, I don't know if you recall those a while back when I was showing you how great it is to be able to look at serial images of a wound. That's what this is able to do. So it really does provide you some great comparative type of imaging that you can use. And what we know is, using some of these imaging software options can really improve the data that you're going to have. And heaven knows if you're going to be doing all of this outcomes reporting and everything, you want to know that the data that you're using is good data. We know that, the problem is people don't measure the same way. So we're going to get a variety of different responses, unfortunately, based upon who does the measurement. So that's why we really like some of this imaging software, because it can really alleviate that issue. All of the technology, it's all HIPAA compliant. And what it gets access, and that's the thing we like. We're able to extend via technology, we're able to extend access to wound expertise, and that is just incredibly important. Also, physician consults can be done, as well as just patient monitoring in general. And we use it for a variety of things, for, consults with agencies, with patients directly, if we're doing an ostomy clinic. There are a lot of different ways we use technology, and it's really very exciting to see how much it's extending expertise for patients. Now, we also use a variety of wearable technology options, and you're going to start seeing those more and more. They are constantly monitoring for a specific wound component. So, for example, such as heat, or that a wound dressing needs to be changed, or something like that. And it will give you that information, which is great. So you're not doing unnecessary dressing changes. That would be very nice, okay? And besides the fact you just got information. You've got feedback on what's happening with your patient and what's happening with their wound. The other thing I want to tell you to be on the lookout for is some new textiles that are being developed. They have actually within the fibers of the textiles, they have Wi-Fi. I know that's hard to imagine, but I promise you it's true. And these will measure a variety of wound conditions, including simple things such as moisture. But we now know, and again, it's great to have that technology, but what does it mean and what do we do with it? Well, we're finding out that it gives us a lot of information that honestly we didn't even know we needed to know 10 years ago. And now it's like, oh, wow, how do I care for this patient without even knowing this thing now? So just keep on the lookout. I'm just telling you that probably more to get you excited about what's coming your way, because you're going to see it. As far as doing an outsourced telewound delivery model, it can go directly from the nurse or PT, or it could go from the patient through a complex wound care platform. and then that goes on to the wound expert. So it's a very direct mechanism, very simple. It's all done through smart technology, and there are some really nice systems out there for you to look at. So I just want to summarize ways that you can improve your wound program. You want to build, again, strong interdisciplinary wound teams. You want to use evidence-based wound treatments and dressings. Standardize your wound assessment and documentation. That is so big. I can't tell you how big that is. Try to become a wound center of excellence. Make that one of your goals. It may not happen overnight, but, you know, you can get those pieces in place, and it's certainly something well worth trying to achieve. Leverage your technology to increase your efficiency, your accuracy. Consider internal or outsourced telewound care delivery models, because they're there. And then develop, collect, and monitor clinical and financial wound metrics dashboard to ensure your success. You've got to know that information. That is just key. So, you know, what I will tell you is this. Our wound healing knowledge continues to grow, and it expands into areas we just never anticipated, such as using smart dressings that, again, incorporate wearable technologies that are going to communicate specific information for prevention and wound management. Okay, so that is just amazing. When I see that in where we have been in our evolution of advanced wound healing, that's really exciting. We are just really, really in the infancy, truly, of our development in wound healing. And I'm really happy you're a part of it, because there's some exciting things ahead for us to look forward to. I want to thank you for your time today. I hope this was beneficial to you, and if you have questions that we weren't able to answer, I promise you we will get you answers to those. You've made me think about a couple of things through some of your questions, so I need to go check out some things too. But again, thank you so much for your time, and hope to talk to you again. Bye.
Thank you, Myra. We do have a couple of more questions and a little bit more time for them. If you have additional questions, please submit them using the Q&A box. We'll get to as many as time will allow for today. This first question we have says, I am really interested in the wound imaging software. Any tips for selecting a program, and where do you find the software?
Oh, goodness. The tips I would tell you is you need to identify what are the basic things you need in your program. And I think the things we've talked about today are the things that just about anybody would need. And I will tell you that the programs, the different wound imaging software programs, pretty much all are going to include that. Things you're going to want to ensure, you want to make sure if you use an EMR that you're able to have those communicate, so you're not double charting. That would be helpful. You want to make sure that it's just affordable. It needs to be in such a way that, you know, your agency can actually afford to use the services, because they're really, you know, again, very, very helpful. Everybody may need something a little bit different. So I would just encourage you, if you go to that wounds outsourced, it's Wound Source, the Wound Source reference that I gave you a bit ago, if you go in there, there's a whole section there on technology. And I would tell you just to go in and do some searches. Do some literature searches, because there's good information out there for you.
All right, next question asks, can you elaborate on nutrition impact on wound healing?
Oh, yeah, absolutely. The role of nutrition in wound healing is probably so underrated, and I don't know why that is. I think it may be just because we kind of think, well, everybody eats, they just don't eat well or whatever. But we know that very clearly for wounds to close, there are several different nutrients that they need to have in abundance, or at least in adequate numbers. So, for example, we need to know they've got enough protein to close a wound. That's extremely important. We need to know that if that's the case and they need more protein, here's where the dietitian will really help you. We don't just make nutritional recommendations in wound healing. Most of that is determined by the dietitian using labs. And where does the patient have a deficit in labs? Okay, do they need more protein? We know that that's going to be important. But if there's someone who has if they have a limitation on how much protein they can take in, okay, that's going to be an issue. That's why the dietitian can help you so much. So we know that certainly hydration has to be adequate. We know that patients need just, the vitamins that are contained within a multivitamin, those need to be contained within their nutrition. There's a lot of scrutiny about using supplements and vitamins and that kind of thing. What I would tell you is there's sometimes that that's the only way some people are going to get the nutrition. So if they're not able to eat, if they have issues like with dentation, for example, or, just a variety of things like that, that could definitely be important for you to consider with your nutritional plan.
Next question says, we have excellent LPNs that provide wound care. Have you integrated LPNs into your interdisciplinary teams?
Absolutely. That's probably my favorite model. Quite frankly, that's probably my favorite model. Man, I love LPNs, and I think they have a tremendous, tremendous role in wound healing, and I'm really thrilled because I've been very fortunate that the LPNs that I've worked with, and I'm talking about virtually working with, they like wounds, and they're really interested, and, all I can tell you is that has been a resounding success for us, absolutely, in working with LPNs. Yes, absolutely, love them.
Next question says, I just want to double check about the penalties under the IMPACT Act. Our agency does report OASIS quality reporting, so would we be okay?
Yeah, I would say yes. The IMPACT Act, what you're going to have to know is PDGM is going to be taking place in 2020. So, up till the end of this year, reporting those 2s and 4s and that occur and then that are, deteriorate, that's not changing at all. That's to the end of this year.
Excellent. That wraps up all of our questions. Any final thoughts or last comments, Myra?
No, I'm just really thrilled that y'all are interested in caring for wounds. And again, I know I keep saying in the future, but guess what? Patients are getting sicker. You're the ones going to take care of them. You're going to be the ones that are going to be getting all these really sick patients. And I can tell you that the technology is just going to become more and more impressive. And I think you're going to have a lot to work with patients. And so if you like wounds, I think you have a lot to look forward to. But again, thank you so much for your time today. I appreciate it.
And thank you so much, Myra. It's been a great presentation. We are honored to have you as our guest keynote presenter today and look forward to continuing our partnership alongside you with HHQI. As we start to wrap up today's webinar, we need to take a look at our resources that are available that are related to the topics discussed today. First of all, we have the HHQI Wound Management Best Practice Intervention Package, which we had mentioned Myra was a technical expert panelist on for, and we are very, very appreciative of her contributions. This is a great comprehensive resource that can be used in your agency. Very, very practical with a lot of resources. There are also free nursing CEs for wound management, which are in HHQI University, and we'll have a little more information about that coming up, including how you can get continuing education credits for today's presentation. We also, in HHQI, have Wound, Ostomy, and Continence Nurses Society guidance on OASIS-D inter-augmentary items, best practices for clinicians, Pressure Ulcer Injury Staging System, Wound Infections Information Sheet, and Home Health Infection Control Prevention Tracker Spreadsheet. So lots of great resources for you. As far as continuing education credit, please follow the directions from the slide that you see here or the email that you will receive immediately following this webinar to complete the evaluation. If you can't recall your username for HHQI University, please contact us at hhqi@qualityinsights.org. And you see there is a link there in the slides that talks about step number 3, where you select Disease Management Course Catalog. The link's also included in the email you will receive momentarily. On behalf of everyone in the Home Health Quality Improvement National Campaign and Quality Insights, we'd like to thank you for joining us for today's special webinar presentation, which is Evidence-Based Practices for Improving Your Wound Management Program. Have a great day.